Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Momna Khan, and I am very thankful to Dr. Sajila and this DST Foundation for giving me the opportunity to have this very important topic to discuss. And I hope so, inshallah, it will be very helpful to everyone present here, and then we will have a recording for later on. So if someone is not available, they can listen it. So our topic for today's presentation is bleeding in early pregnancy and the pregnancy of unknown origin. And before starting my presentation, I will have just a brief introduction of mine. That I have told you that I am Dr. Momna Khan, but unlike Dr. Sajila, nobody knows me. So I just want to tell you a little bit about myself. Can you have another slide, Dr. Sajila? Yeah. So I did my MBBS from Liaquat University of Medical and Health Sciences 2003, and then in Hyderabad, Pakistan. And after that, I did my FCPS in 2010. Here, I forgot to mention that I did my MRCOG in 2020 also. And initially, in the beginning of my clinical experience, I worked as an ObGyn specialist in Alais Medina region. And after that, I started as a consultant gynecologist. I just worked for another few years in Aga Khan Maternal and Child Care Center, Hyderabad. And from 2016, I'm working in a Bilawal Medical College as an assistant professor since 2016, and now I've been promoted to associate. And I have more than 15 publications, both in international and local journals. And my area of interest is managing a high-risk pregnancy, and recently I'm very much interested in performing laparoscopic surgeries. So that was my brief introduction. So what is the objective of today's having this lecture or presentation is that by the end of this presentation, what will be our objective? My objective today is that you all will be able to define what we call as a pregnancy of early pregnancy bleeding, how definition, what are the different causes of early pregnancy bleeding. And because even a small spot in the early pregnancy can be a cause of sinister pathology. So it's very important to know the causes of early pregnancy bleeding and how we are going to evaluate the patient with early pregnancy bleeding. And my today's main focus will be on the pregnancy of unknown location. So how we are going to manage the patient with the pregnancy of unknown location. Dr. Sakira, can we go into the back slide? No, back. Yes, like this. Thank you. So bleeding in early pregnancy is defined that any bleeding in pregnancy up to 20 to 22 weeks of pregnancy is defined as a bleeding in early pregnancy. That is the age of viability. Usually for the Europeans and the Americans, it's 20 to 22. For us, it is 24 weeks of pregnancy. So next slide. So what are the causes of this bleeding in early pregnancy? It can be from a small thing that is nothing, no problem, to major gynecological emergencies. So it can be an implantation bleeding. We will discuss in a while what is implantation bleeding. And it can be a symptom of a miscarriage. It can be an ectopic pregnancy. And it can be a gestational trophoblastic disease, or which you usually, in generally, we call it as a molar pregnancy. And it can be a postcoital bleeding just because of increased vascularity of the cervix during pregnancy. There can be a bleeding with the intercourse, and really it can be a cause of gynecological lower tract pathologies like any infection, any cervical polyp, or any cervical cancers, or sometimes even the pre-malignant disease of the cervix like CIN. So here in the picture, we can see the main causes of the bleeding in early pregnancy. And the top one is the implantation bleeding. I was telling you in a while that it is nothing. When the fertilization occur in the ampullary part of the fallopian tube, and this fertilized embryo just move towards the uterus and it gets implanted in the wall of the uterus. So because of the increased vascularity, there is some breakdown of the vessels in the wall of the uterus, in the decitua, the part of the endometrium that is called as a decitua after pregnancy. Then it is here the small blood vessels will leak and it will cause implantation bleeding, and it usually occurs 10 to 12 days after fertilization. So usually occurs at the time of the missed periods. And the next cause is the miscarriage. So it will be that actual bleeding in the placental site, and there is a risk to the baby that the mother can lose the pregnancy. And it can be an ectopic pregnancy. This is very important, that any bleeding in early pregnancy, we have to see the causes, because we can miss these important things, and this can affect the life of the mother. Even the mother can die because of this situation. So it can be a pregnancy that is outside the normal uterine cavity. It can be in the tube, in the ovary, in the vagina, in the cervix, in the abdomen. So it's very important to look for this cause also. And the last one is the important one is a molar pregnancy, when there is or there may be no fetal tissue, or along with there is overgrowth of the placenta. In general term, we can say that it is the placenta, the trophoblastic tissue, that starts overgrowing, and we might have some fetal part, or there is no fetus at all. And these are the another causes I was discussing about. That is a polyp, that is a small fleshy structure. They are coming out of the cervix, or it can be a cervical cancer. We can see a growth. And we have seen these patients in our routine practices. We are seeing these patients. So none of them is the cause that we have not seen. They are very frequently, we are encountering all these conditions in our clinical practice. So the one very important is that implantation bleeding, because every bleeding in pregnancy is not necessary to be having a problem, or it will ended up in a loss. But it can be a just implantation bleeding. I told you, when the fertilized egg attaches itself to the lining of the uterus in order to begins growing. So the small vessels get ruptured, and usually occur between 6 to 12 days of after fertilization. And it is seen in the 15% of cases, and usually it is harmless, and we have to do nothing. But the important thing is that how to differentiate between that it is an implantation bleeding actually, or it is a periods, because as I told you, majority of them occurring at the time of the missed periods. So there is a few differentiating points between the implantation bleeding or periods, and and the pregnancy. Three things are very important: whether patient is pregnant, so it is implantation bleeding, or it is a periods. So implantation bleeding, a patient will have some symptoms of pregnancy also with that, like the mood swings, headache, nausea, lower abdominal pain, lower back pain, lower abdominal mild cramps. Along with that, the plantation bleeding is usually either pink or brown in color, and it is just in the form of the spotting. Whereas if it is a periods, it can be very red, and the flow will be heavy. And in the plantation bleeding, usually the cramps are mild or no cramping at all, and thin watery discharge is there. And but in the periods, it will be very crampy, and the consistency is thick red, and may have the blood clots also. And this implantation bleeding usually self-limiting. We have not to do anything. It will last for 1 or 2 days, and but in the periods, they will last for sure for 4 to 5 days or 7 days, and usually occur around 28 days of cycle. So every monthly it will bleed. So these are the few differentiating points between the implantation bleeding and the periods. So here is the important point. So what is most important in any patient who present with us with the bleeding in early pregnancy is how to evaluate the patient, and to find the cause of the bleeding, because as like we said, from nothing to it will be a life-threatening emergency to the mother life. So it is very important that any patient with have bleeding in early pregnancy, we have to ask the patient to attend the early pregnancy unit or any gynae emergency unit, and we have to take a detailed history first, and then we have to examine the patient, and then we have to go for some investigations according to the history and examination finding to find the cause for her early pregnancy bleeding. So it's very important to ascertain that what was her last menstrual period, and whether she confirmed that she is pregnant or not, and how with the help of some blood test, or with the help of beta HCG, or just urine pregnancy test. And very important thing, next thing is to ask about the severity of the bleeding, how much she is bleeding. It's just in the form of spotting, it just heavy with the form of the clots, in the form of the clots, and how she's feeling at the moment. Because simultaneously, if you are asking a history of the patient regarding the bleeding, we have to assess the general condition of the also. She might need any resuscitation if she's bleeding very heavily. So all these things should be in our mind, and we have to go, and we are doing, we have to take it together. So we will just see the general condition of the patient, and along with that, we will ask the questions regarding to assess the severity of the patient. And we will ask her whether she has passed some tissue-like structure to make sure, to know that whether to assess the situation, basically whether she's aborting or she's passing some grape-like structure to ascertain that it might be a molar pregnancy. And along with the bleeding, we have to see whether she is having pains or not, because pain may be the one of the symptom of miscarriage, or it can be one of the symptom of ectopic pregnancy. So it's very important that we ask about the pain and what is the severity of the pain. And we had, if she had any other associated symptoms like fever, malaise, vomiting, any bowel or bladder symptoms, and shoulder tip pain, because this can be pointing towards the ectopic. Because in ectopic, there can be a tubal rupture inside, and this bleeding inside the peritoneal cavity can irritate the diaphragm, and the patient typically present with the shoulder tip pain also, that I have very much pain in my shoulder also. And we can ask about any, this bleeding is preceded by the coitus, that is any post-coital bleeding. And in the obstetrical history, it's very important about the, we have to ask about the past obstetrical history, whether she had a past history of ectopic or any molar or any miscarriages in the past. So it will also help us to find the reason, and will give us the clue what could be the cause for this bleeding. And another very important point in the history is to know about the surgery, whether she had any surgery in the past, so that it will help us in deciding the current situation, and then to find the cause. It might be the cause for this because the molar surgical history, prior pelvic surgeries can be associated with ectopic. And the most important thing is the blood group of the patient, that any patient who presented with the bleeding in pregnancy, it's very important to know about the the blood group of the patient, as any bleeding in the pregnancy, if it is above 12 week of pregnancy, then we need to give the patient anti-D, anti-RHD to prevent the RH incompatibility. And even if the pregnancy bleeding is before 12 weeks and it is in heavy severe bleeding, or we need some intervention, then in that situation also we have to give the anti-D to the patient also. So this is very important. That's the thing that we are asked about the patient, whether the pain is minimal, like in the miscarriage, the pain is not so much. But if she's aborting and the products are in the os, cervical os, then she might have a severe pain. Any acute agonizing or colicky pain, the shoulder pain, and the fever. These are point towards the causes, as I told you, keeping the differential in the mind. So this is the classical triad of ectopic pregnancy. If the patient is the case of ectopic pregnancy, she will give us the short history of amenorrhea, like 6 to 8 weeks usually, and then she will have abdominal pain, and this abdominal pain will be very severe, and she cannot bear the pain, and she might be vitally unstable, and it's presented with the irregular vaginal bleeding. So this classical triad is very important as compared to the miscarriage. In the next slide. Usually, in the miscarriage, patient presented with the amenorrhea and then bleeding, and the pain is the last event. But in the ectopic, after amenorrhea, the patient will have a pain and then bleeding. That's very important. Then, once we have certain the type of the bleeding, the severity of the bleeding, any associated symptoms, and then the general history and then obstetrical history, it's very important to examine the patient. And we will have a general physical examination to assess the vital status, the blood pressure, the pulse. She might be normotensive or she might be hypotensive, and the pulse might be raised because she's bleeding. And according to the severity of the bleeding, per abdominal examination is very important to see whether what's the size of the uterus. Because the uterus may be enlarged in cases of molar pregnancy because of the overgrowth of the molar tissues, and also for abdominal examination to see whether there is any tenderness or rebound tenderness or any abdominal distension, like in case of ectopic pregnancy, when there is a bleed inside the abdominal cavity, the patient might be in pain, and the abdominal distension might be there also. So this is very important again. Then after birth abdominal examination, as per rule of thumb, we have to do a speculum examination of any patient presented with a bleeding in early pregnancy to see whether there is any local pathology like cervical pathology. Like we said earlier, there might be a polyp, there might be some local cervical lesion which we can see, and we have to also see that whether she is bleeding from the cervical os, and like it's a uterine bleeding, and also whether she is passing any products or the os is dilated or not. So it's very important to go for the speculum examination in the end. Also, we might need in some cases, because nowadays we are going for investigations are like ultrasound is readily available. So usually we don't need the bimanual examination, but we can have a bimanual examination. Next slide, Dr. Sajila, like this. So what we are going to do in a bimanual examination, we'll put one hand in the anterior fornix and the other hand in the abdominal wall, and to see we will see the size of the uterus, whether it seems to be pregnant uterus or not. Also, we can check the fornices for the any bulges or masses. So any extreme tenderness on fornices, palpation, or rocking sign of the cervix. When we'll move the cervix, the patient will have a severe pain. This is pointed towards an ectopic, or bilaterally enlarged uterus, ovaries or enlarged uterus point towards the molar. And so this way, this bimanual examination can help us. So what are the investigations we are usually doing in a patient with the presenting with a bleeding in early pregnancy? First of all is the serum beta hCG, to see whether first confirm the pregnancy, and then how many weeks she is pregnant, what is the level of beta hCG. Then we have to go for the transvaginal ultrasound to confirm the pregnancy, whether she is pregnant, and then what is the location of the pregnancy. It is inside the uterus, it is outside the uterus, or it is a normal pregnancy, it is not a molar. So all these. And then along with that, to find the cause, we will go for the routine investigation to assess the general condition of the patient, like the blood group of the patient, like the complete blood count, picture of the patient, that she might be anemic, we might to need arrange blood, or to look for other things. So I will not go in detail of the miscarriages, ectopic, and molar, because these three are the different topics given to my other colleagues. So they will present in the coming few inshallah lectures. So we will just go through in a few slides about the miscarriage to have an idea about early pregnancy bleeding with the miscarriage. So miscarriage is quite common. 1 in 5 pregnancies ended up in a miscarriage. And it is defined as an expulsion of a pregnancy or embryo or a fetus at any stage of pregnancy when it is incapable of independent survival. So it includes all the pregnancies that are less than 24 weeks. So what are the causes? Most of the cause time, it can be idiopathic without any causes, or it can be because of some chromosomal abnormalities, and some abnormality in the fetus, structure abnormalities like anencephaly or any other structure abnormalities, then can cause all these problems. And it can be a problem with the uterus. It can be a septate uterus or any bicornate uterus, which is a reason for these miscarriages. It can be because of infection, medical disorders like thyroid and diabetes in the mother. It can be one of the cause can be a cervical insufficiency when the cervix is short cervix because of hereditary problem, or any surgery to the cervix has been done in the past, or any thrombophilia and hormonal imbalances. Next slide. So these are the common type of the miscarriages we are encountering in our clinical practice. Number one is the threatened miscarriage, when there is a bleeding in the decidua basilis. and still the baby is okay, the heartbeat is okay, the cervical os is closed, we called it as a threatened miscarriage. But once the cervical os opens and the baby and the sac is coming out of it, then it is called as an inevitable miscarriage. The process has been started and we cannot stop it. And sometimes half of the tissues expel out and the half still remaining inside. We call it is an incomplete miscarriage, or sometimes the patient will present with us with a complete miscarriage. And one of the differential cause type of the miscarriage is missed miscarriage. When there was a baby, there was a heartbeat, and the baby's heartbeat is stopped, and the patient has no any complaint, no bleeding, no pain, nothing. She just have a baby is missed, the heartbeat is stopped. We call it a missed miscarriage. Next slide. Next slide, Dr. Sajila. Yeah. So, back, Dr. Sajila. No, 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 no. You have to go back. Yes, this one. Yes. Yes, next. Yes. So this is the one of the picture. Patient came to us with bleeding. She was pregnant, and we did an ultrasound. Ultrasound shows completely aborted uterus. There is nothing inside the uterus, and another is showing with some pieces inside the uterus. So this is just a picture of ultrasound. If you are going to go for TVS in these patients, so will give us a clue. So ectopic pregnancy, as I said, it is one of the conditions that can affect the life of the mother. The mother can even die, and because of the massive hemorrhage inside the abdominal and pelvic cavity and then abdomen. And it is the pregnancy implanted fetus. When we said the fertilization occur in the fallopian tubes and the baby enters in the uterine cavity and get implanted in the wall of the uterus, anterior posterior wall of the uterus or fundal part. And this sometimes this implantation does not occur inside the uterus, but apart from the uterine cavity, it can implant it somewhere else, like in the tube, in the ovary, in the cervix. It is called as an ectopic pregnancy. And this ectopic pregnancy, I told you the classical triad will be like amenorrhea with the bleeding, with the pain and then bleeding. And this is very important to keep the differential of ectopic in your mind if you are dating, because this ectopic can be a emergency situation in gynae, and we have to deal it urgently to save the life of the mother. The next is the molar pregnancy. I told you this is there will be no fetal tissue, or there will be some fetal tissue, and because of the problem with the chromosomes, there is an overgrowth of the trophoblastic tissues. So there is nothing inside, only this trophoblastic tissue, grapes-like structure can be seen on the scan, and even the vaginally, the patient is passing this grape-like structure. And in this molar pregnancy, the only treatment option is suction evacuation to evacuate the uterine cavity. But after going all the important investigations, because these need long-term follow-up, and these pregnancies can ended up in a invasive mole and choriocarcinomas also. But the good thing is that the molar pregnancy has a 100% cure rate if we are going to diagnose it on time and follow it on the way it is recommended. So it will not going to harm women. But it's important is that diagnosis should be done on time, and the management will be according to the standard protocol. And then we will coming few presentations in the weeks, and you will see that how the molar is going to be managed. Then this is the last thing we are going to discuss today, the pregnancy of unknown location. This is very important. And we have seen the patients coming to us, they're very concerned, they are very much anxious that, doctor, I am pregnant, but my ultrasound doctor is saying that you are not pregnant. So it's very stressful situation. And not only they need support, that's their right to us, that we have to see the situation, and we have to see what we can do, because it can go in any direction, this pregnancy of unknown location. So how we are going to define when pregnancy of unknown location, when there is no sign of either intrauterine pregnancy, ectopic pregnancy, or retained product of conception. We did a scan to the patient who presented with pregnancy, with a bleeding in early pregnancy, and we cannot see any anything on the ultrasound in the presence of the positive pregnancy test. She was pregnant. She is pregnant, but we cannot find the pregnancy. And pregnancy site will not be visualized in around 10% of the early scans in the early pregnancy assessment unit, because early pregnancy assessment unit contains a dedicated sonologist. But in our setup, usually we don't have like this, but we have an emergency gynae setups. And in 30% of the other units, the pregnancy still can be missed. even with the setups also. So what can be the possible outcome of this pregnancy if we are not going to show the pregnancy on ultrasound, but still the positive test? It can be an early intrauterine pregnancy, but we did a scan very early, and that's why it's not visible. And later on, we will find it's a normal ongoing intrauterine pregnancy. Or it can be failing pregnancy for known location. The pregnancy test became positive, but and then we are not able to see anything, and the pregnancy test will also become negative with time. Also, we call it as also the biochemical loss. We just found a positive test on the labs, but no evidence on the scan. But the important thing is that here also we have to rule out this 10% chunk that is ectopic. This is very important because sometimes we just reassure the patient that okay, it's not a pregnancy, or it was just a positive and everything will be okay. You just go and repeat the test, and then they come to us in emergency with a collapsed state because we missed the ectopic pregnancy. This is very important. And then it can be a complete miscarriage. The patient was pregnant, then she had a bleeding, she lost the pregnancy, and it was a miscarriage. That's why we are not able to see anything on ultrasound. And very rarely other source of this positive pregnancy test, this beta HCG, will be like then HCG secreting ovarian tumors can also be there. That's why the test is positive, but we cannot see anything on the ultrasound. So it's very important that how to deal with these situations. As I told you, the patient is very anxious and they want to know why we are not able to see the pregnancy. Can we move to next slide, Dr. Sajila? Yes, this is a scans. It can be any possibility. It can be inside the uterus. It can be outside the uterus. It can be a complete miscarriage. So this is the findings when we are doing a scan of the patient with the pregnancy for known location. We cannot see anything in the endometrium. The uterus is very clear. Even the adnexes are clear on scan. We cannot see any pregnancy sac. Next, presenting. They can be asymptomatic. Majority of the pregnancy of unknown location, which I have seen in my practice, they are usually asymptomatic. They come to us with a positive pregnancy test. They are very happy about their pregnancy, and we did a scan to them, and the scan shows no pregnancy. And they can present with the bleeding. They can present with the pain, or sometimes they can also present with a history of fainting, but the scan is showing nothing. So these are the point here. We should be very careful in managing these patients. So assessment, whenever any woman presented with a positive pregnancy test, but no evidence of pregnancy on transvaginal scan, then again, the history does matter here also. It's very important to take a detailed history to rule out any risk factors for ectopic in this patient also. And clinical assessment and the beta HCG and progesterone level will be carried out. So this progesterone level here will give us an idea about the viability of the pregnancy and whether if it is an intrauterine pregnancy, whether the pregnancy will survive or indicate us. And because this progesterone level reduces, indicate the failing pregnancy. So that's very important to see the actually read out the level of progesterone. So level of progesterone less than 25 nanomole per liter is usually associated with a non-viable pregnancy. However, viable pregnancy is reported in less than 15 nanomole also. Even the high progesterone level more than 60 is strongly associated with the subsequent viable intrauterine pregnancy. But a small number of ectopic can also have a very high progesterone level because the pregnancy there, the pregnancy is growing. When we can see the heartbeat in ectopic. So still, if it's a high progesterone level, we have to keep the suspected ectopic in our mind also. And it's very important to explain the woman the three possibilities in this situation can be an ectopic pregnancy, can be a persistent pregnancy for known location, or even it can be a viable pregnancy. So it's very important. So these women should have a further follow-up with serial beta HCG and or ultrasound. All these should be explained to the woman. So the most common outcome in pregnancy of unknown location is the spontaneous resolution of pregnancy of unknown location. Next is the subsequent viable intrauterine pregnancy, or very small chunk can be an ectopic. So if the patient is asymptomatic, the close follow-up and is needed, that is required in the form of beta HCG and ultrasound, and she should present in emergency if she develop acute pain. And this surgical intervention in the form of laparoscopy and laparotomy is only indicated if the woman has symptoms. So this chart is very important to understand. If the patient presented with the pregnancy of unknown location, and what is usually we have a gray zone, gray area about which beta HCG the pregnancy sac should be visible. Like on transvaginal scan, if the beta HCG is above 100, sorry, above 1000, we can see the intrauterine gestational sac. Or if we are going for transabdominal scan above 1500 international unit beta HCG, we can see the gestational sac very easily. So if the beta HCG is more than 1000 to 1500 and we cannot see any gestational sac inside the uterus, though this should be considered as an ectopic and should be dealt in the line with ectopic. But if the beta HCG is still less than this discriminatory zone, like less than 1000 to 1500 ml, then we can see what is the progesterone level of this patient. If the progesterone level is less than 20, then it's likely to be a failing pregnancy, and she should be advised that repeat beta HCG in further 7 days. But if the beta HCG is done in 48 hours, when we are going to do the repeat beta HCG, we are going to do the repeat beta HCG usually in 48 hours to see the doubling time. So if the beta HCG is raised more than 66% from 0 to 48 hours, it's likely to be an intrauterine pregnancy, and she should be advised that follow-up scan in 10 to 14 days. But if the beta HCG after 48 hours is raised, but it is less than 66% raised, or it is a plateau, means the same readings are coming, there is a possibility of ectopic. So it should be monitored closely with beta HCG and TVS until diagnosis is made, or until beta HCG drops to less than 15 international unit per liter, that is, it became negative. But if the beta HCG is, if the beta HCG is persistently plateauing or fluctuating, it can be persistent pregnancy of unknown location, we call as after 3 consecutive sample with no diagnosis. And in this situation, we will just go either for conservative management, or if the patient is symptom with pain, with bleeding, we can give her methylprednisolone also. But if the initial beta HCG, as I told you earlier, if the beta HCG is more than 1500 and we cannot find any pregnancy on the ultrasound, it could be it must be a probable ectopic pregnancy, and all the management options will be open for this lady according to the situation, in the form of conservative, in the form of the medical, in the form of the surgical management. So I hope it was hopeful to all of you, and thank you. If you have any question, feel free to ask.